This presentation was recorded at the 12th International Conference on Rapid Response Systems and Medical Emergency Teams.
Thank you for letting me speak at this conference. It's a real honour, and I welcome you to this presentation I'm going to give about patient safety lessons from maternity claims. It will incorporate a lot around the importance of governance, because actually those are frameworks that actually safe. But claims data, as Jane did say earlier, usually have quite a long time lag, but they can actually, with other sources of truth, actually tell us how we are performing in terms of patient safety, which would include our incidents and complaints. So today I'm basically going to talk about how us as healthcare providers and clinicians can actually look at that and see what, the importance of good governance and patient safety. So I know this is a bit of repetition, so please bear with me. But as you know, obstetrics is one of our greatest sources of financial revenue when it comes to claims. About 296 million, and that was over a period of 5 years, and that constitutes of 42% of our claims that come to the VMIA. But thanks to the prompt programme, we've actually seen a reduction in claims to do with obstetrics. So obviously there is an impact from actually providing prompt. And what we are actually now seeing is actually an increase in our emergency department claims. So that's another area that we need to address possibly in the next couple of years. So I tend to look at a little bit outside of the box, because there are other insurers out there that do claims data or collect claims data just to see what is actually happening in terms of claims, because claims can actually tell us a bit of a trend of what is actually going on. And the NHSLA, which is in the United Kingdom, actually produced a report in 2012 which looked at 10 years of maternity claims. And what they found was the total cost of claims was around about £1.3 billion, and actually constituted less than 0.1% of births becoming subject to claims due to negligence. So actually, the UK does do a lot more deliveries than Victoria, but they actually found that the actual medical negligence is quite low, and therefore they have a premium rate on baby born around about £700 per birth. But when they actually drilled down and looked at the data, what they found was actually, they found three very common causes of claims, which were the management of labour, caesarean section and cerebral palsy. And then they drilled a bit further down from that, because they really wanted to see why those were, the reasons why claims were coming forward. And what they found, namely, that actually there's a combination of things, that cerebral palsy and the management of labour with CTG interpretation actually accounted for 70% of their high-cost claims. And then they drilled a bit further, and they actually found there were other, what we call emerging risks in insurance, and those are namely, of course, CTG interpretation. I don't think we're going to find a fix-all problem to that, but perineal trauma and uterine rupture was actually another big reason why they were starting to get claims in that sort of area. And so their report concluded that the most effective way to reduce the financial and human cost is to continue to improve the management of risks associated with maternity care, focusing on the prevention of incidents linked to management of labour and CTG interpretation. So obviously management of labour is very important, and that includes the use of syntocinon and, of course, CTG interpretation. So I asked my claims team at the VMIA what they think are the most common themes when it comes to claims in medical indemnity, and CTG interpretation was actually at the top, particularly the use of intermittent auscultation and decision-making of when to go from intermittent auscultation to continuous monitoring. And following those particular protocols, they get changed regularly, we do know that, as more and more research comes forward, and we're all bringing on new systems as well that we all need to be trained up to be able to use adequately. But one of the things she did actually say to me was the use of syntocinon, which is obviously, for those who work in maternities, around the augmentation and induction of labour. And that actually mirrors a lot what the NHSLA found as well. And the other one, and I'm going to talk to you a little bit about a story that I was involved in, was around errors on admission and misconception of complexity. And that's really around misdiagnosis and delayed diagnosis and delay of treatment, but also not escalating when things are not going to plan, and more importantly, not actually taking into account the risk profile of the patient. And the other two at the end were really around caesarean section, which was about decision time to delivery, and vaginal deliveries, which were shoulder dystocia and perineal tears. Now, the case I'm going to talk to you a little bit about, just for a couple of minutes, was actually a claim that I was involved in. It involved a neonate who actually ended up with quite severe HIE and also necrotizing fasciitis. And when we look at claims, it's not just looking at the clinical impact of the claim, it's actually looking at the whole claim as a whole, as a system failure. And this was a classic system failure across the board. Can you imagine a busy maternity unit? The staff come on, they're already down to midwives because somebody's called in sick. There is a poor culture in the unit. This is us and them. Management don't listen to us. We've been having problems with our people going off sick. There was quite low motivation, demoralisation in the unit at the time. And this woman was looked after by a junior midwife who'd only been in her role for around 6 months. And she was looking after a woman who's been augmented for prolonged rupture of membranes, was on syntocinon, CTG, and the baby eventually was delivered by ventouse, and he needed antibiotics. So she was a junior midwife. She'd only just done her course but hadn't done her competency, so she could not administer the antibiotics. The PED decided that he was going to come an hour later just to allow mum and baby to bond, and he will come and cannulate the baby later. Now, she tried to call the PED numerous times to come to labour ward to actually get the baby cannulated, and when he eventually turned up, he cannulated the baby, prescribed the medication, and left very promptly. So she was left with a drug chart, and she was left to give antibiotics, but at the end of the day, she couldn't give them because she was not competent. So she went out a number of times to ask midwives on the first week, can you help me do this, because I need to make sure this baby gets his antibiotics in time. And eventually, the labour ward coordinator said, labour ward's very busy, you need to move the patient to postnatal ward, they'll give it there. And as a junior midwife, she didn't argue and took the baby over to the postnatal ward, put him in a bay, and handed over to the midwife, who was actually not responsible for that bay. So, lo and behold, this poor woman was actually ignored for 5 hours. She went out and asked numerous midwives, can you give my baby my antibiotics? And they were like, yes, in a minute, we're a bit busy, we'll get there, usual thing. Round about night shift arrived, and she pulled the emergency buzzer. The baby by that time was severely compromised. He had gone to a respiratory arrest and had a mottled skin complexion. And in fact, he had fulminating sepsis. And you can just visualise it. It's not just a CTG interpretation or caesarean section or time to delivery. It's actually a multiple factors that actually contribute to actually harm being done. So this is where we come to the whole issue around what happens in industry and inquests. And I don't really want to delve too much into this because we know some of these cases quite well, particularly around mid-staffs and some of us in Victoria around Bacchus Marsh. But what it is really illustrating is that there are failures across the board, and they're usually not just in one area. They're across the board from top to bottom, horizontal, vertical, you name it. And what happens in these cases is there's usually recommendations, and a lot of hospitals come to us and say, I don't want to be another mid-staff, or I don't want to be another Bacchus Marsh. So why do the systems fail? Well, pure and simply, when we look at those particular incidents, claims, complaints, as well as those larger inquests, what we find is sort of very familiar themes, which include not just not having a just culture. And in this claim particularly, there was a lot of demoralisation within the workforce. People were not very keen to actually admit failure, and they were not keen to put in incidents. In fact, in this case, the incident form was not put in for 48 hours. So you can just imagine it. And this was also a factor in mid-staffs, which was the Mid-Staffordshire NHS Trust, that people were not reporting and not admitting failure. There was an absence of patient involvement. I think that's really key. We are actually serving the public. We are serving our communities and we're serving our patients. And in these cases, the patient was basically put on the side, rather like that woman being put in a bay and forgotten about for 5 hours. We're not very good at doing open disclosure. We're not very transparent. That's what they found. Not having consistent reporting systems for analysing and understanding adverse events and including reporting of near misses. This was not the first time antibiotics were not provided on time. When we did an audit, we found that 50% were done within 2 hours of birth. So you can imagine it, we were really sailing quite close to the wind. And communication is poor, particularly between management and particularly between the staff on the ground. The handover of care in this case was literally a line in documentation: handover done, signed, left, no ISRRS, nothing. So we don't even know whether antibiotics was actually mentioned. Focus on hospital administration on achieving financial targets rather than patient safety, and this is very common in these cases, but in this particular case that I've just told you about, actually our priorities for our management was to keep our workforce quite low. They were trying to save money. They didn't want us to get agency staff when we were short-staffed. So we were really working with a very, very low staffing threshold, regardless of what capacity was. And we closed numerous times because we just didn't think the actual unit was safe. But on that particular day, they decided not to. And actually, it's around the finances, about balancing that act. Poor clinical audit programme. We all know about accreditation. A lot of the hospitals that were involved in these big inquests were actually accredited, both in the UK and here. And actually, sometimes we take accreditation as being a tick box exercise rather than it actually being a meaningful exercise that actually helps us find our gaps. Absence of an appropriate and effective complaints investigation system. That's always very common, particularly around the lack of transparency and open disclosure. Lack of resolution of underlying safety system. Well, in this case, which I just explained to you, we didn't have any safety system. It could have happened the following week. And the absence of clinical governance programme. We were in the midst of a new way of looking at how we ran our clinical governance at the time in our trust. So you can see, even just with a claim and large safety system failures, there is always a trend. So we talk about the first line of defence, which is basically your business operations, what you do on the shop floor. It's your actually just developing your risk and control environment. And then we follow on by our second line of defence, which is around our oversight functions. So this is slightly the level above us, the executives around finance, HR, IT, legal, risk management strategies around, and particularly things like case reviews and M&Ms and peer reviews of actually major incidences that have happened in our units. And then the third line of defence is around internal and external audits, so really looking at what is actually happening outside of our hospital and what is actually happening inside of our hospital, and actually asking the hard questions, which then get fed back to our board and executive and audit committees. And I assume that most of you have an audit committee. So some of us at VMIA actually do quite a lot of work with our boards. Oh, sorry, 3 minutes, okay. And that's really to try and educate them about actually changing that message from away from finance, but thinking about the strategic plans, how they engage with their community, but also thinking about the patient. And there are a few structures around that, which is basically integrate quality and safety governance within risk management, which is very important. It's really thinking about having risk management requires a strong and sustained commitment for the board. Influence on patient safety culture is very important. Addressing gaps in board skills and knowledge, and we do a lot of that. We do a lot of board training. We do talk a lot about patient safety. We bring up things like mid-staff and Bacchus Mile so they understand that have to ask the right questions. And to really upskilling their skills around this area. But I think one of the most important for me is strengthening consumer engagement. We are providing a service to consumers and we're providing a service to patients, and they should be really at the core of what we do. Particularly trying to encourage boards to think about how they use their surveys, analysing their trend data, looking at their complaints investigation, particularly the outcomes of those, and maybe even suggesting whether they do walk rounds, actually go on the ward and meet the staff, meet the patients. Do any of your hospitals do that? I see a few hands going up. Great. And then, of course, improvability of internal and comparative quality benchmarks. It's very important for them to realise that it's not just a singular thing, but it's also they have to look at what's happening outside of their health service as well. I've got one more slide and then I'll be finished. So basically, just for you guys, for those middle management clinicians, what can you do? Well, obviously, I would always say have a good culture of incident reporting, particularly your near misses. They are your, I suppose, your canary in the mine. They tell you, where a system is failing but hasn't quite failed, so hasn't actually become an adverse event. And also make sure you look at your complaints management, because your complaints can tell you a lot. Do not blame and learn. Very important, because if you throw the finger at people, people won't report, and it will just be, clamp down culture. Being transparent is so important. Using evidence-based practice, particularly reviewing your policies around that. And if something goes wrong, review your policy and see whether your policy is actually fit for purpose. Regular multidisciplinary competencies and training, which is like prompt. Very important that you work as a team. That's the only way you save patients. A regular internal audit programme, which is fit for purpose. It's actually meaningful. It says what it's supposed to say on the tin, as I would say in the UK. And obviously good communication and good documentation. So use the tools out there like your U's, your trigger warnings, your ISRRS, but also make sure that you're not writing war and peace. Make sure that all the care you provide is patient-centred, and most important, learn. If I have to leave you with one thing, is if something goes wrong, learn from it. We teach this to our children every day. Our children make mistakes. Humans make mistakes. We have a whole faculty of new ideas called human factors, which is around human errors. But really what we need to do is when we make a mistake, we must learn from it, and we must embed it within our culture. And that's all I'm going to say. And that's just a little bit of a summary at the end, which is the sort of things that I've just covered. Thank you.